Because of time limitations, we're very anxious to hear from you all. I'm going to fast forward to Derek wrote the book, Jean's Way, which was pretty bold, saying, I hope my wife die. And with impunity, there have been a couple of other books written by people who've helped their loved ones die, again with impunity. Two other books written in New Zealand about helping their loved ones die, where there was a prosecution. So it takes a lot of courage to write about it, and it's a risky business. Then he remarried, moved to Los Angeles, worked for the LA Times, and because of the response and the financial support from the sale of this book, started the Hemlock Society in 1980. Now I'm going to fast forward to another country. So many foreigners around here. Dick Macdonald is a Canadian who was a GP practicing in Canada and encountering a lot of people who needed help to die. And then what happened, Dick?
We're in a short court here.
I asked for short.
Don't fall off.
Of course, it's okay. Excuse my back.
It's okay.
I'm one of those physicians who has been practicing for so long that some of you, I can tell by hair color and other features, probably are in my age group. But it was normal for us to help our patients to die, and especially in general practice. Because before 1973, we had no means to save lives with ventilators and other technology that was developed in the 70s. So from the 1950s, I had 20 years of practice before we had a means to actually save a life of someone whose heart had stopped and they'd stopped breathing. So it was normal for our patients, if there was no more to do for them in the way of treatment, and if they had an illness that was going to take their life, they went home from hospital. 85% of our patients died at home in the 50s and 60s. And so my perspective on this subject comes from my early years of practice, in which we visited our patients. I'm sure some of you still remember house calls. We did many house calls in those days, and we provided medication that eased them into a peaceful death with pain medication and sedation. And that was just normal, and that's the perspective I had when I first became aware, serendipitously, of the Hemlock Society after having moved to the States. And I sort of was seduced by the climate of California after some very long, colder winters in Alberta. So when I, by chance, saw an ad for the Hemlock Society wishing to have a medical director to help communicate their philosophy to physician organizations and others, and I thought, well, that sounds very rational. I'd read something of Derek's writing and about a meeting he'd attended and spoke at in Berkeley. And so I was, at that time, just cutting down my practice and semi-retiring about 1993. So I applied for this interesting position. And as it turned out, quite a few other physicians actually had applied. So after the Hemlock board had reviewed the applicants, they invited me to become their medical director, which was a very part-time thing. But I found nothing unusual about the idea that a patient who is very near the end of life from an illness from which there's no chance of recovery that that patient should, if they chose to ask for support and help in dying, that was something that was in, and should have been in, a physician's area of responsibility. And my feeling has remained the same ever since the 50s, that I should not abandon my patient because they are dying. And I should help them to have as peaceful an exit as possible. And we were never criticized, I'll tell you, even though we helped patients to die in the 50s and 60s. Even the leaders of medical organizations and the leaders of religion were not criticizing us or coming after us because we may have given a much larger dose of medication so a patient could die peacefully and when they chose. So it was rather easy for me to transition into becoming a spokesperson, a doctor spokesperson about the subject. And that from 93, we fast forward, as Faye likes to say, to a point when in the Hemlock Society headquarters moved to Denver, and Faye became executive director. And that was around 96 or 7, I believe, Faye. What happened then was that although I was traveling a lot and speaking at meetings, not just Hemlock meetings, but at national medical organizations, and I found there was a lot of resistance in organized medicine. Now, organized medicine in America is an oxymoron in itself, as I'm sure many of you understand. I can recall one of the first meetings of the Academy of Family Practice that I attended to speak about dying with dignity. And when someone saw my badge, a doctor, we were at a social function, and one of the doctors, who happened to be a leading family physician teacher, saw my badge saying the Hemlock Society. And he said to the group who were standing around us as we chatted, "Well, I see you're with the Hemlock Society. Well, no patient has ever asked me to kill them." And I said, I can certainly understand why. I must say there were some wry smiles in the doctors surrounding us. So I became known to my colleagues where I was practicing in Chico as someone who spoke about this, certainly at our staff rounds and board meetings of the hospital and so on. And I had the experience more than once of a doctor at a medical function, but at the social part of it, introduced me to his friends, saying, "This is the doc I want around when I'm dying." And it gave me the opportunity to respond that I hope you will listen to your patients and what they wish. Because what the patient wishes, physicians should take into account. And we should be partners in a patient's health. I always felt my patients and I cooperated. And I also feel, as I did then, that what was in the best interest of my patient was my medical ethics. Medical ethics should not be based on religion. Medical ethics should be based on what is in the best interest of that patient. And if a patient says they are suffering unbearably, that is their assessment, and I accept that. Now, that doesn't mean that it's easy now for physicians to provide patients with a peaceful dying process. There is a great deal of opposition, both from the medical organization leaders and from religious leaders and from the law. The law says we must not do that. And of course, religious leaders say only God can decide when your life ends. So we are at risk, any physician is at risk, if they overtly help someone to die. And that's why we support there being legal changes, that there should be legislation that permits a patient to ask their physician for assistance in dying if, in their estimation, their quality of life has descended to the point that there is no more value in keeping living with the symptoms they have. That has to be an individual's understanding. We cannot be the ones who decide that a certain person's life is no longer worth living. So we certainly support the attempt again, which has been tried several times over the last 15, 20 years in California to have a law passed. But sadly, that law that is has been already introduced in the Senate, SB 128, is something we should support. But I'm hoping the language of the law will differ from the states that currently have law. And in Oregon, as I'm sure you all are aware, has been having a law functioning since 1998. And and now has Washington State and Vermont also have laws. But all those laws say that the patient must be terminally ill. And terminally ill is something physicians are supposed to decide. You have to have two physicians who will say, you're going to die in 6 months, not 6 months and a day, not 6 months and a week, but in 6 months you will no longer be here. And there is no way we physicians can make that decision. I can tell if a patient is going to probably die within 2 to 3 days because of their condition. It has become obvious they're not going to make it through a weekend or a week. And we can advise the family of that. But I always like to tell about George Burns, who lived till just shy of 100. And he was asked by a reporter, Mr. Burns, what have been the best times you've had in this last decade of your century? And he puffed his cigar still as he was at 99 and said, well, I think the best times are when I've dated the widows of 3 doctors who told me I was going to die 10 years ago. And he was very correct. There is no way anybody can make a decision based on what we think is going to be the duration of their life. So the laws, and I hope they will change, the one being proposed in California, the law should address the quality of life. It should address a patient who has an illness that is not going to improve, that is irreversible, and has great suffering. And that suffering needn't just be in pain. It may be the suffering that you have when you can no longer enjoy any part of your life. So that we hope that people will help push for a law that has that rational approach to when someone may choose to ask their physician for assistance. And I think I will pass this over now to Faye, and she will continue on directing us. as to when we should talk again.
So we're covering a lot of years here, and so I want to fast forward or backward or something to when I took over the Hemlock Society in 1996. And at that time, when desperate people called us, we were very fortunate to say, well, read Final Exit. You can buy it online, and it will tell you how to end your life. Have a good journey. But after the Supreme Court of the United States ruled in 1997, that there was no constitutional right to assisted dying, overruling two lower courts, which said there was, and after one of our members left us $50,000, and when I called to thank her, I found out that she had gone in her car and shot herself. And that seemed so horrible, that our own member should have to die a violent, lonely death, that we used her money to start what was the Caring Friends program, in which we trained volunteers to go to people's homes who were Hemlock members, who were seriously or terminally ill, and who were considering hastening their death, and tell them what they needed to do if they were going to do it, what their options were, and then go back, should they decide to do it, and be with them when they did it. So we started the Caring Friends program against any legal advice of our lawyers, who said don't even think about doing it, until we got a sympathetic lawyer who said, well, I understand, just make sure that you're not violating the law because you're not assisting. So that meant we don't physically assist somebody, and we don't provide the means. We can be there, be present when it happens. But we did not think that was assisting. Since then, so Caring Friends was a Hemlock program. I don't know if there are any Caring Friends volunteers here, but we trained 28 people in San Diego. Was our first training. I'm looking at Arthur Metcalf, because at that time he was, raise your hand, Arthur. He was chairman of our board, and his wife, Sally Troy, who many of you remember, arranged a lot of things in San Diego for us. So we had our first training of 28 volunteers here in 1998. We didn't really have a method then, and so by the time the second training came around in 1999, again here in San Diego, Derek had developed a program called New Tech, in which people who were engineers, divers, whatever, came together to find a way to have a peaceful death that you could self-administer. And out of that program came the helium method, which is described in a lot of information on the back table. And so that's the method that we recommended to people in the Caring Friends program. The Caring Friends program was a non-medical program to provide people with a peaceful death, and not just terminally ill people. So we differed from an organization like now Compassionate Choices, which advocates medical assistance for terminally ill people only. So during that time, so Dick very easily segued from his role as medical director of Hemlock to his role as medical director for the Caring Friends program. And during that period worked with many people who had a peaceful death, who were extremely grateful for that. We still use Final Exit, the book, and we told people to read it because it's got a lot of helpful information in it. Then in 2004, our board decided they didn't want to be Hemlock anymore, changed our name, got very conservative as we got more and more money, and started merging with another organization, Compassion in Dying. Changed our name to End of Life Choices, and we knew that the Caring Friends program would be gone. So we started a new organization. Derek and I were two of the founders. There are a lot of Hemlock board members who were also founders. And we carried the activities of the Caring Friends program over to the Final Exit Network. So that's a national organization that does the same thing. Makes calls to people who are members, once they're screened medically, advises them on what they would need to have a peaceful death, and they are present, the volunteers are present if they decide they do want to hasten their death. We have such a volunteer here, Sally. Acknowledge yourself. Sally, Dr. Sally Hall. There are a lot of doctors, by the way. Dick is not the only one, but it's a non-medical program. They don't function as doctors, per se, when they're exit guides, because it doesn't involve medicine. So that's where we are today, and when you look at the future here in California, we have pending this legislation, which would probably bring us to the same point as Oregon, Vermont, and Washington, as Dick said. If the General Assembly decides to pass it, there have been bills in the General Assembly before, never get out of committee, so we don't know. There's a possibility of a ballot initiative, and many of you, especially Arthur Metcalf over here, remember what we did in 1992 with a ballot initiative in California. Anybody here worked on that, collected signatures? Oh, how nice, thank you. So nice to see these old faces. Yeah, we collected about 35,000 signatures here, but you needed 450,000. But we did qualify to get on the ballot. We had no money left, and we got 46% of the vote in California. If we had money, like the Catholic Church poured into it, we would have had a law here for death with dignity way before almost anybody else. So that's another possibility. If the General Assembly doesn't come through, there'll probably be a ballot initiative which may cost $40 million. The other possibility is a lawsuit that many of you, I've written to many of you, brought by Catherine Tucker, the former legal director of Compassionate Choices, challenging the prohibition against doctors helping patients die in California. And we have been supporting that. We are sending matching funds. We've sent about $6,000 to Catherine's organization, Disability Rights Law Center, and we will match any monies that we are sent to us for the Disability Rights Law Center and send them to her. So that is promising, but it's produced a different kind of result, not a specific statute. And then there's the final exit network. So if all else fails and we don't have a law, or you don't qualify for the law, the final exit network can be there for you. We are now, the final exit network is now in its third lawsuit. Our services are, I'm talking now, the final exit network had quite expensive because we go anywhere in the country at no charge to the patient. And we are involved in these lawsuits now, one in Minnesota, which goes to trial in May. So those are the options, and I think you probably have sampled what Dick and Derek said, so they have a lot more to say. We've been talking and talking all weekend, talking about what's going on internationally, talking about what's going on in other states, talking about different methods of dying. But I would like to open it up now for questions for Dick and Derek, me if you need to hear from them more extensively. What have you got there, Mitz?
Stan Herman's program.
Well, this is Stan Herman's brochure. You can keep it up there and you can help yourself to it. Stan Herman, raise your hand, Stan. He gets programs all over the city. We put them on our website. You can contact him on his website, Caring Advocates. We don't need to publicize the programs because the brochures are in the back room. Thanks, Mitz. So any questions? Yes?
Help me understand this medical...
Mitch, do we have a mic rolling?
I can speak up.
Okay, not everybody can. Help you understand?
This thing called palliative care that we hear about from the medical world, and where does it draw its lines?
Dick?
Sure. Palliative care, as I'm sure some of you may have been exposed to with either family or loved ones that have required palliative care when they had an illness that was near the end of life, but pain was unendurable. And so palliative care just means palliating the pain that comes, especially with certain diseases, and particularly that comes with cancer of the bone and that type of pain, where even the best palliative care specialists admit that some 5% of their patients near the end of life are unable to have their pain adequately controlled. So that palliative care is just simply that, palliating terminal, usually terminal pain, but not necessarily terminal. So the difficulty with palliative care and with some palliative care specialists is that they do not believe, some don't believe, that palliative care should go to the point of ending the patient's life, which medication can do. And so in the medical world, we have a way around that, in that at the instigation of the physician may increase the pain even to the point of ending the patient's life. And that happens much more frequently than is known generally. But what we call that in medicine is double effect. And the patient is told that yes, we can relieve your pain, but it may end your life. But I don't mean for it to end your life, I mean for it to ease your pain, even though the doctor knows that this will end life. And I call that the Hippocratic oath. Clearly, we should, in medicine, we should be able to be open and honest about what we are doing to patients, and we should be doing more for them, because even when we can cure an illness, we shouldn't stop caring about the patient. So that I think physicians should more readily be able to increase the pain medication with that known risk that it will end life. The ultimate end of pain or palliative care is having terminal sedation or end-of-life sedation. And that's where nothing controls the pain, so a physician, usually a anesthesiologist, is involved in hospital. Of course, the patient must be in hospital, not at home. And they anesthetize the patient with medication, sedation, and pain medicine, to a point that they don't stop breathing, so it has to be carefully titrated. And they slowly die over several days of this terminal sedation. And the physician feels better about that. Then, so again, I criticize that but physicians are caught in a bind. If the patient dies too soon, you mustn't die too soon, or you'll get the physician in trouble. So we may not be able to hasten your death, but we are allowed legally to keep you miserable for as long as possible.
Of course, hospice uses palliative care. All palliative care is not hospice, but hospice uses palliative care. And if you remember the case of Brittany Maynard, how many of you read about Brittany Maynard? 29-year-old woman from California who had a brain tumor that was causing terrible headaches, seizures, and speech problems and everything else. Newlywed, decided to go to Oregon to use the Oregon Death with Dignity Act, which you can't just walk in and say, okay, I'm ready. You have to establish residency there, which she did. So she was able to find a doctor to give her the medication. And she specifically, although most people who use the Death with Dignity Act do have hospice beforehand, she specifically said no, because hospice neither prolongs nor hastens death, and she didn't want to prolong her life. Her life was miserable. So she bypassed the palliative care option altogether and used the Oregon option. Does that answer your question? Any other questions? Here's one, Sally. Are there any other ways to die besides the final exit network with dementia? One of the reasons we started the Final Exit Network, preceded by the Caring Friends program, was to be able to work with people with early dementia, people who were still mentally competent, who could self-administer whatever means there were. So we did talk about that at length today, actually, and we are really sad that people have to give up quality of life while they're still lucid in order to end their lives peacefully. There are advanced directives. Stan has one. I have one that's on Ergo's website that says if I get to this point and I specify which point that I can't recognize my children or I need 24-hour care or whatever, then I would like somebody to end my life. And I would like them not to be punished legally because this is my wish. This is my advanced directive. Of course, that doesn't have any legal weight, so I don't know what would happen in a court of law if anybody did that. I also have in my advanced directive, do not treat any infections, and I think you can specify that you want to be made comfortable, but not treated. And then Stan talks about not eating and drinking as an option, which he can explain to you in his book. So those are all ways, and none of them are satisfactory. There was a big article in the Union Tribune today about how many billions of dollars it's going to cost us to keep people alive. And personally, I don't want to be among those people to be kept alive and all the consequences that follow. So, I don't know, maybe Derek or Dick have some other ideas here for dementia.
Add something, especially as the question related to dementia, I think you said. And the difficulty with patients with dementia is, number one, they don't qualify even where there is a law, because no physician can really say that that patient is going to die within 6 months.
And they have to be mentally competent.
And they have to be mentally competent, as Faye indicated. So what we have available is the patient who has a diagnosis of dementia, and 80 to 90% of all dementias are Alzheimer's, which may be very, very prolonged. 10 years, some are more quickly into the end of life, but it's usually a long, drawn-out dying. But if a patient has a neurological specialist in dementia say that their testing has shown they have an early dementia or early Alzheimer's, they should have at least 2 confirming neurologists say that. And then they unfortunately must prematurely end their life. I will tell you that those with whom we have tended their choice of dying, we thought it was very premature in some of them who really seemed still quite able to function. But they didn't think it was premature. They had experienced loved ones with dementia who had died, and they did not wish to risk waiting through their window of opportunity time to end their own life until they might not still be capable mentally to proceed with that or handle it. So there are the main way that dementia patients die now is the same as what happens in hospice care, where the vast majority of patients in hospice care die from stopping hydration, nutrition and hydration. And that can be prolonged, for my point of view, 2 weeks, sometimes longer, although it can be shorter if they have a caring physician or a caring hospice director who will order adequate sedation and pain medication, then it hastens their death. But as Faye has already said, hospice cannot admit that they hasten dying. That's their national motto. And that was based on the motto that came from the first hospice movement in England, and that was through a physician nurse who was a nun as well. So it was a religious way to handle dying by not hastening, but not delaying death. So there aren't many ways that you can hasten your own death unless you have a physician who will provide you with sedatives, strong sedatives that, if you accumulate enough of them, that you could hasten your death. In the way that the laws in the states that have them use a barbiturate of 9 grams, which is 90 capsules of 100 milligram Setanol, and that is what's used where it's legal. So, but most physicians won't prescribe barbiturates because they're too effective. Nowadays, most sleeping medications are tranquilizing. They're not true hypnotics and true sedatives.
Yeah, let's go to some more questions.
Okay.
I'd like to hear what Derek has to say about Alzheimer's. Let's make the answer short.
Well, people approach me all the time by telephone or internet mail about the onset of Alzheimer's, their own or that of a loved one. And the difficult question they ask is, when shall I take my life? Well, that is an enormously difficult question. But I, as kindly as possible, say, if you really wish to do this, you must do it very soon. Because if you delay, you will find yourself unable to decide and nobody able to help you. So I hear of a few cases of people ending their life in the first few weeks of Alzheimer's, but not many. It must be an agonizing, difficult decision. But it has to be early or not at all.
What's happening with the administrative bill that's wending its way through our legislature right now? And is there anything we can do to hasten that other than shoot all the legislators?
That's not going to help, there'll just be more. The bill is now in the Health Committee of the Senate and gets voted on March 25th. I will send out the names of the members of the Health Committee. They're not our representatives, nobody here from San Diego. And you can write to them. And then it goes, I forget, to Judiciary, I think, so that's another committee with more people to write to. Derek once said what's going to happen here is a persistent legislative process. So that's what's happening. And it's happened here in California before. It may not even get out of the Health Committee. So the best you can do is to write to these people first and then get other members of the General Assembly to support it. Discouraging them. Yeah?
I recently attended a training with the hospice group, and I asked them about the question about palliative care, and I specifically said, are there any pains which cannot be helped with palliative care? And the people who were doing the presentation kind of tiptoed around that question and would not address it, leading to it. I think what you said, that there's certain kinds of pain that cannot be addressed. Is that correct? Or?
Yes.
Because that was something they just refused to actually answer.
We worked with a patient who had terminal cancer, and her pain was not helped by They tried very hard. She had a wonderful relationship with her hospice people, but she was allergic to the pain medications. So she kept throwing up every time they gave her different opiate types of medication. And they understood that she wanted to hasten her death, and why. And the existential pain of not being able, as Derek said, to do what you're doing, what you want to do, loss of autonomy, is the first reason that people give in Oregon for using the Death with Dignity Act. And immobility, incontinence, dependence, all these things that are not pain, physical pain. Hospice, if they're candid about it, will admit that they can't treat everything that makes people uncomfortable at the end of their lives, but sometimes they're not.
Derek?
Go very careful about telling people in hospice of your intention to bring your life to an end. Hospice is a mixture of good people and doing their level best, with great credit to them. But there have been instances where a seriously ill dying patient has mentioned to the hospice worker in their house, oh, I'm going to end the life, or I belong to the Hemlock Society, let out their feelings. And the hospice nurse, male or female, has telephoned the police. And the police's duty is to come round immediately and say, who's committing suicide? It's what they call a wellness call. So sometimes can lead to trouble. So you've got to assess your hospice worker very carefully before you let your ideas flow.
Also, hospices have confiscated books like Final Exit around that have been left around the house. If they find the helium tanks, out they go. And they often make you sign a pledge that you will not end your life. They may bolt the doors so you can't jump off your balcony. No, just keep quiet about it. Hospice is great, but just keep quiet if you're going to end your life and destroy and put your books away. Yeah.
Thank you. I have that question.
You can ask it, but I do advise reading Final Exit. But
Derek, you want to handle that one?
I didn't probably grasp the question.
What's the question?
the question was, why are not the drugs recommended for euthanasia euphoric producing? No. What is the question?
Right. The question
Can you make it very
why,
succinct?
why are sedatives used at all instead of morphine or a morphine derivative exclusively?
Well, first of all, people who are very sick generally develop a tolerance for morphine. So we can't tell you what dose of morphine to use. It may end life by respiratory depression, but it may not if you're used to using large doses of opiates all the time. And that's what happens with pain. So the formula that Derek developed,
Tell it, how do you reach that conclusion?
You mean for a barbiturate overdose?
Yeah.
Yeah. Well, first of all, out of textbooks. Secondly, out of talking to pharmacists who were sympathetic to our movement, and talking to doctors, and experience. I assembled the list of what were the lethal dosages of certain drugs, taken carefully. And then, as with new tech, which Faye mentioned, we were looking at it in the organization New Tech for methods in which a dying person could end their life without the involvement of a doctor and without being able to get the necessary barbiturates, which is so difficult. And we developed, after several experiments and tests, the helium hood method, where a person can acquire the bits and pieces and with a tank of helium and a tube or two, put the gas into a plastic bag over their head, and death is instant. Brain death comes if you ingest 4 or 5 mouthfuls of pure helium. The brain death will follow within seconds. So done properly, the helium hood method is very fast, very effective, and absolutely painless. It takes a bit of care and planning to set it up. And there used to be a lady here in Southern California who sold ready-made kits, Charlotte Hydorn. But 3 years ago, was it now, the FBI raided her and shut her down. So nobody else has had the courage to make ready-made for-sale kits for the helium method. To counter that as best we could, I've written a pamphlet, which is an addition to my book, Final Exit. The pamphlet is how to make your own helium hood kit. It describe step by step how to do that.
I know Dick has some ideas about this too, but I just want to say, I don't know what drugs make you euphoric, but I can tell you that most of the people that we work with are so grateful to have a way out of their suffering that they're pretty euphoric. They're grateful, they're happy, they're relieved. They are so glad that somebody will be there to make sure they have a good death.
Dick.
Yeah, and just to address what your question raised was the euphoria of pain medication, which does occur. But as has already been mentioned by Faye, the tolerance to pain meds is increased very quickly. If we're treating someone for pain, we have to generally increase the amount of morphine or other narcotic every week to catch up with the pain that has overcome the pain medicine. Whereas with sedatives, like strong barbiturates, the barbiturates put the brain to a deep coma to the point that breathing stops. Whereas with pain medication, you can't guarantee that. With the massive dose of barbiturates, you're almost certain to have that control your breathing to stop.
Our last meeting was 3 veterinarians. Did you go to that?
I-
We were all very jealous.
I'm so sorry I missed that.
Very jealous about how the pets were treated by these veterinarians when it was time for them to die back there. Are you saying that you can die with medical marijuana?
No, but it relieves the pain that you're talking about.
Sure.
Will.
We hear about people dying from OD of drugs, recreational drugs. Is that a possibility? I would call that euphoric death, probably. If you OD on cocaine or heroin or something like that. Does that work?
It is said that anybody who dies of a heroin overdose always has a smile on their face. The trouble with street drugs is you don't know what the dosage is. In our Right to Die Film Festival, we showed a Canadian film. Why can't I think of the name of it now? The Barbarian Invasion. The man who was dying, his son arranged to find a heroin addict to cheap out the heroin for him to first get pain relief and then ultimately to end his life. And everybody was around. It was very peaceful. It was very nice. If you have access to pure heroin, I'm sure that would work. Dick, yes?
Well, the problem with using anything other than a strong barbiturate is that we can't guarantee what dosage, how much you have to take, when you have to take it, how long it will be effective. We can, with virtual certainty, like 99%, guarantee that if you have 9 grams of barbiturate, you will die, unless someone discovers you and resuscitates you. So that our program in Final Exit Network and in Caring Friends, when it existed, was that we wanted a method that was sure, that was as speedy as possible, and was as peaceful as possible. And you don't get that with other drugs, whether they're narcotics or otherwise. And the proof comes from some 30 years now of experience in the Netherlands, where, as most of you know, the Netherlands has had euthanasia legalized in 2002. But they had experimented for 15 years before that by physicians figuring out what dosage was needed. And using that 9 grams, they ended up as that was the dosage that would guarantee a peaceful exit.
It says it, people call me all the time and say, it says in my local paper that this man or woman has taken their life with an overdose of OxyContin or some such drug. And why can't I use it? Why don't you put it in your book? I say, wait up a minute. How long did it take that person to die? Did they die in pain? Did they mix it with anything else? When those type of deaths happen, it's usually also with other drugs. They're, drugs that they're taking for recreation, or with a lot of vodka. And I say to these people, you don't know exactly what happened, particularly how long it took, or whether it was painful or not. So that's my answer to the people who call and say, why can't I use such and such a drug?
And you don't want it to be unsuccessful.
Unsuccessful, yeah. Willis pointed out that I think it was Russell Ogden who showed that 50% of the people who tried to end their life with AIDS were not successful. Was that by a gun? I can't remember. Certainly I think over 50% of people who try to shoot themselves don't wind up dead. They may wind up with an eye missing or something, but they often don't die. Have we covered that subject? It's a very important subject. I know you're all concerned about it.
And drugs also.
Drugs can mess up your head too, that's right. Carbon monoxide, if you decide you want to die in your car, which Derek does not advise, if you're caught, you can wind up brain damage. So
that with a new car.
And with the catalytic converters, you wouldn't have enough carbon monoxide to kill yourself. Yeah.
No. The question is, can other people be present when the person takes their life justifiably with either helium or... No, in America it's quite clear from numerous court cases, other people can be present, but they mustn't do anything. They mustn't lift the cup to mouth or put the bag over the head or anything. But to be present is not a crime. Some policemen think it is, but they're soon straightened out and told it is not such a crime.
Dick, you've been with patients who've had their families and loved ones and
yes.
Sally has.
I think some of the question was, is there a risk to other people from the helium? No?
No.
Oh.
I was just thinking of the caregiver themselves. Do they have any?
No, although it's no longer a crime to commit suicide, which it used to be. You probably, many of you will remember 20 years in some states or longer in others. It used to be a crime, and the only way they could charge you with the crime is if you failed, of course, and then they sentenced you to life. We've had numerous cases where the law has learned that people, their loved ones, have been present with someone who died because they've been open about it and called the authorities to say exactly that their father, mother, or loved one has ended their own life and they wanted to report it, and what do they do now? The authorities have to come out, usually a representative of the law, which could be a sheriff or a city officer, and they must come usually with a representative of the coroner's office, who is either a nurse or a paramedic who has the right in most states. That representative of the coroner can say that death has occurred. But the officer has to look around and make sure there's no signs of a struggle, broken windows, so someone's come in and done this, even though they've already been told that the person has ended their own life. And we've had some experiences where the law enforcement people and the people from the coroner's office have said, well, it appears that your father did the right way. And they said, usually we find there's a firearm involved, and it is just so terrible for their loved ones. So we've actually had that expression, your dad did it the right way. And it looks as if he died so peacefully. And so we've had some experiences like that.
But most of our deaths in the Final Exit Network,
There's somebody present, not just us, but family members, friends, whatever.
some people have lots of people present.
The first stage of defence is to leave a copy of the book Final Exit at the bedside with the pages marked where you think it's in, and leave a note. It says, you know, I did this for the following reasons and nobody helped me, and this was my choice. Those are the first lines of precaution from keeping law enforcement satisfied.
Next question, yes. The question is that somebody here said that people in Oregon didn't sign up soon enough. I've heard that from hospice people, and that's very true with hospice, that people sign up at the last minute to get hospice care when they have suffered up to that point and they could have had their suffering alleviated. But in Oregon, there's quite a procedure. You have to get 2 doctors to examine you, independent doctors, to determine that you have 6 months or less to live. There's a 15-day waiting period during which you have to request it twice, and once, and the third time, in writing, witnessed. And if either of those 2 doctors who examine you thinks you're not mentally competent, or you're being coerced, or you have serious depression, then they order a psychiatric or psychological exam. And then after the 15 days that you've gone through all that, and you're still alive, you get this piece of paper. This is it, Physician Aid in Dying. It's a piece of paper, a prescription. And then there's a 2-day waiting period before you can get that filled. So dying in Oregon is not an impulsive act. Or in Washington or Vermont, and if the law passes, it will be not an impulsive act here either. Yes. Oh.
Thanks.
Oh, Stan. Make it short, please. You usually give a speech. Well, in the Final Exit Network, we don't make a video particularly, and we do arrange for somebody to find the body. Derek talks about what precautions you should take in the book. And if you are a member of the Final Exit Network, you're very well advised about how to plan this, how to be found, what to do after that, all that. And we always advise people, if they can, have hospice. It makes it very much easier to just call hospice and say, somebody say that you've died. Does that answer your question? No? No? Yeah. Oh. Okay, so Billy's given us a lot of thought and suggests body donations to UCSD. Every once in a while, maybe every 2 years, we have a program on what to do with your body. And we always really advocate that UCSD body donation is a very good idea, and it does eliminate a lot of the questions that get asked. And I'm sure your daughter-in-law has been very helpful in that regard. Yes. Well, a ballot initiative is the hardest, most expensive way to do it, so the lawsuit is one way that's cheaper, and the going to the General Assembly is the other way that's cheaper. Yes, compassionate choices is the main driver of a ballot initiative if it happens, but also the Death with Dignity National Center. And they both are trying to change the law. We will also match funds that go to DDNC, the Death with Dignity National Center, just because Compassionate Choices has something like $14 million, and you're welcome to give to them, but we're not going to match those funds. But the others, if you send your check here with DDNC on it, we know that it goes to them, and we will match it. So we will all try to do whatever is necessary to change the law, even if it changes twice, even if it goes to the legislature or a ballot initiative and the lawsuit wins, it's fine. We want all bases covered. And we certainly have been collecting money here for a long time, and we intend to help, as we did in Washington in 2012. We sent $35,000 matching from our members. And when Hemlock Society was going, when I was head of it, when Derek was head of it, we contributed to every ballot initiative that there was in this country. So, yes, we are interested in changing the law, but we don't want that to be the only way. You have to wait for the law to change, and you won't have a peaceful death. No, you're not talked out there. Mitz, are you raising your hand? It's, 3 o'clock? Okay, so I don't hear any other questions. I don't hear any interest in going to bullies. I hear somebody's got a hand up here. No. Oh, Barbara, is that you down there? Barbara is asking the question, how do you avoid being put on a ventilator if you are not competent to say no, something like that. And she's referring to the program that was on KPBS about vent farms. Actually, they said in that program that the loved one can take the person off the ventilator. It's very interesting. They choose not to. But in this country, and thanks to the Supreme Court decision in 1990, every American has the right to refuse or stop unwanted medical treatment for any reason, even if it leads to their death. There is no reason to be put on a ventilator against your will if you have designated someone to speak for you and have told that person you don't want that artificial means of life support, and it's in your advance directive. If you haven't taken those precautions, then you could very well be put on artificial life support forever. That's almost easier than just trying to end your life if you're not. Yeah.
I just want to say thank you to the three of you. You really are true pioneers.
Thank you very much. It's very rewarding to work with you all here today and such a good turnout. And we're pleased to help as long as we have your help in general.
I'd just like to add that there are many people, volunteers. Our organization, Final Exit Network, we're all volunteers. We have no paid people who are working with the members. And I tell you that you would, if you met any of these volunteers other than ourselves, you would be so amazed at the variety of people who have come forward, volunteered, not only to pay their own expenses, to be trained to be volunteers, but they are some of the most wonderful people in the world. So appreciate the organization. I hope you will join any organization involved with Dying with Dignity and support them, not because you're close to dying, but because you believe in the philosophy that it is a human right to have control of your own dying process.
Amen.
Thank you very much for coming. Please join us as members of the Hemlock Society of San Diego. Join the Final Exit Network. That's your best insurance, in my opinion. And we'll be around for a little while to answer questions. Derek will sit on that throne over there and sign anything.